It's 8 o'clock. It's good to see you here this morning. Thank you so much for joining us for week 4 of Cardio-ECHO Tackling Type 2 Diabetes. So we'll begin with a welcome. I'm Shannon Switkowski. I'm the clinic coordinator. Dr. Dungan.
Hi, I'm Kathleen Dungan. I'm an endocrinologist at Ohio State University.
Hi, I'm Mary Lee Clemens. I have a student, Grace, here with me. I'm a pharmacist at UT Internal Medicine in Toledo. Thank you.
All right, Dr. Dungan, I'll turn it over to you.
Great, thank you, Shannon. So here is the agenda for our ECHO clinic today. And we will begin with a didactic presentation and a case study as usual, and then a wrap up. And don't forget, as you come up with questions, put them in the chat, or even better, at the end of the didactic and the case, we'll have an open discussion. If you can turn your video on, especially during that open discussion, that would be really great to facilitate interactions amongst the group. And you can unmute your mic when we have those discussions and you're going to ask questions. So with that, let's get started. Here is our disclosure statements once again, and those were also sent to you by email. And today the didactic is going to cover new and emerging therapies for type 2 diabetes. I admit this is a bit ambitious, so we won't be able to cover everything about new and emerging therapies, but I'll give you a flavor of the most recent and how that impacts care. And so these are the specific objectives, describe the role of GLP-1s and SGLT2 inhibitors, particularly with cardiovascular benefits. And the second is to describe current recommendations for selection and titration of insulin. And the third one is new developments in technology for diabetes, type 2 diabetes. Okay, so first off, I would just like to remind everyone, when it comes to implementing glycemic control, we're definitely improving the risk of microvascular complications, but in terms of mortality and cardiovascular issues, that's been very difficult to establish through glycemic control alone. And so these are just a snapshot of some of the many trials that have been done to investigate whether implementing tight glycemic control or tighter glycemic control provides mortality benefits. And you can see across the board, there's really mainly a neutral effect on mortality and cardiac death. And with one exception in the ACCORD trial, in which there was an increase in risk of mortality, and as a result, the study was stopped early. Now, these studies were done before the era of GLP-1s and SGLT2 inhibitors. And so these drugs in particular don't cause hypoglycemia. And that is not the only potential explanation for the increased risk in the ACCORD trial, but could at least be a contributor. And it's also worth noting here, okay, get through these, that in particular, if we wanted to establish any kind of cardiovascular benefit, you have to have the right population. In the UK PDS, this was conducted, one of the first studies ever done in patients with type 2 diabetes. It was conducted in patients with newly diagnosed type 2 diabetes with rather infrequent complications at baseline. And at the initial data reporting in 1997, there was this demonstrated reduced risk of microvascular disease, but it wasn't until 10 years after the study was completed that there was demonstrated benefit in terms of cardiovascular and mortality. And so if you're going to suggest that glucose control by itself is going to reduce mortality, you're going to have to follow them for a really long time. And that may not be feasible in today's day and age. Okay, so what about GLP-1s and SGLT2 inhibitors? Well, there might be some nice synergistic effects that are common to both of these agents that might offer a benefit. They both reduce A1C, obviously. They both have modest weight reductions. They both result in modest blood pressure agents and blood pressure lowering as well as lipid lowering. And they are not blood pressure or lipid lowering drugs per se. And you can see here in the color coding, the green is what SGLT2 inhibitors, that some of their purported and observed mechanisms of action by which they might provide some benefit and in terms of both glucose control, cardiac outcomes, renal outcomes. And then the purple is those mechanisms demonstrated by the GLP-1s. And so you can see that there isn't a whole lot of overlap here. And so there might be reasons why we might be able to even use both of them. But certainly the possible benefits are very difficult to predict from just looking at mechanistic studies. And it should be without saying that neither of these agents cause hypoglycemia, and that is one of the possible reasons why we might see an increased risk of trying to implement tight glucose control. And then overall, if we were going to kind of put all of these mechanisms together and try to understand how there might be a cardiovascular benefit with these drugs, I think we can summarize it as follows. So for GLP-1 receptor agonists, it's most likely some kind of an atherosclerotic mechanism. The cardiac benefit that emerges takes, quite some time to observe. And in comparison, the SGLT2 inhibitors might have more novel benefits that are more specific to their mechanism of action, perhaps some effects on plasma volume and fuel metabolism that are a bit more complex. And certainly neither of these are very well understood. But what we do know is that in many cardiovascular outcomes trials, we have seen benefits. So what is the landscape of cardiac outcomes trials? Well, there have been a lot of them conducted for DPP-4 inhibitors, GLP-1s, and SGLT2s. Right here is just the landscape of DPP-4 inhibitor studies that have been conducted. And these are all across the board neutral in terms of major cardiac events. There are a couple that may have resulted in an increased risk of heart failure that we don't fully understand why to this day. When it comes to GLP-1s, there are even more studies that have been done. And I want to preface this first by saying that you cannot compare these individual agents very easily, because these studies were done in different populations, and the study conduct and the way that the study was implemented can have an effect. So we can't say for sure that there's a class effect or not a class effect based on all the studies that have been done thus far. Nevertheless, in the studies that have been done, there are several with liraglutide, semaglutide, dulaglutide, and albiglutide, which is not on the market in the US, in which cardiac benefit and major adverse cardiac outcomes have been demonstrated. And in the other studies, it's not that there might not be benefit, it's just that the studies weren't as similarly designed, so we can't answer that question. In terms of SGLT2 inhibitors, we also, in terms of major adverse cardiac events, there are some demonstrated benefits across 4 of the 5 studies that have been conducted thus far, and all of them have demonstrated reductions in risk of hospitalizations for heart failure, and they have all demonstrated some renal benefits. And so these drugs are going to be pursued for those indications independently of diabetes, and they have been successful with dapagliflozin, and probably soon will be with empagliflozin for an indication for heart failure therapy. Okay, so this is a meta-analysis of the multiple cardiac outcomes trials that I wanted to present, even though it's actually a little old, even though it's a year old, because it doesn't include some of the more recent studies. But since it includes all of these classes of agents, I thought it was useful. And so you can see here in terms of 3-point MACE, which is any acute MI, stroke, or death, that both GLP-1s and SGLT2 inhibitors demonstrate benefit, and a DPP-4 inhibitor is neutral. In terms of non-fatal MI, we see some borderline benefit of GLP-1s. In terms of non-fatal stroke, there is significant benefit for GLP-1s, and for SGLT2 inhibitors in terms of cardiac death. In some of the secondary outcomes, so all-cause death, there was benefit for both with little reason to suspect major differences between the two classes of agents, and definitely benefit with SGLT2 inhibitors that exceeds that of GLP-1s. And then finally, we have renal outcomes, which are beneficial in both groups, but more so with SGLT2 inhibitors. And we see that in hard renal outcomes like doubling of serum creatinine and end-stage renal disease. Okay, so how does this affect our management? So as I presented a few weeks ago, you may remember this, we start off with metformin and lifestyle changes, but based on whether someone has cardiovascular disease, atherosclerotic cardiovascular disease, or chronic kidney disease of some sort, that will determine what is our second agent. And also remember that the ADA recently revised its guidelines recommending that these medications be added regardless of baseline A1C. So that's where we stand here. So GLP-1s with cardiovascular disease or SGLT2 inhibitors. And if a patient has a predominance of heart failure or kidney disease, an SGLT2 inhibitor is preferred as first line. And then we go down the line to considering other things like hypoglycemia, weight gain, and cost, which I won't go in detail. So now I wanted to switch gears a bit and just review the most recent recommendations for intensifying to injection therapies. GLP-1 receptor agonists, you'll notice are listed first here. There is one oral GLP-1, and so we would include that as well. And these drugs are now considered to be first line before starting insulin. So the only time you would think about insulin first would be at extreme A1Cs, if you think a patient has type 1 diabetes, or if they are, symptomatic. And if you might consider an initial combination therapy if the A1C is above 10 or if it's 2% above target. And so combination therapy meaning combination injection, both basal insulin plus GLP-1. And so if a patient is not at goal, whatever that goal might be, then we would add a basal insulin. So that could be started at a fixed dose of 10 units per day, or you have the option of doing a weight-based dose of 0.1 to 0.2 units per kilo. And then ideally have the patient self-titrate. That can be somewhat challenging, so an alternative would be to have some careful telephone follow-up phone calls, or have a nurse or educator or pharmacist do some follow-up phone calls or communications to ensure that titration is being conducted. So, and why is it that we use a GLP-1? Well, this is just an example of a meta-analysis that was published a few years ago. There are other studies like this and several now head-to-head studies of GLP-1s with basal insulins. And you can see here the green is the short-acting GLP-1, the blue is a longer-acting GLP-1, and arguably you would see even more difference with the newer GLP-1 semaglutide, which is not in this meta-analysis. But in general, there's a modest A1C reduction. So that's not terribly compelling. However, there is a difference in weight loss, certainly, compared to basal insulin, and a significant difference in hypoglycemia, about 15% less. So in the totality of evidence, plus the cardiovascular benefits, a GLP-1 is preferable to basal insulin if it can be done. We know, however, that diabetes is a progressive disease. And in part, this is because of progressive beta cell failure. You'll see in the red line here, the secretory function of the beta cell declines, such that most people with type 2 diabetes need insulin if they have it long enough. Insulin resistance may or may not change throughout this period. And so we do have to go to insulin therapy. This is just a general picture of what basal insulins look like when they're in use clinically throughout a 24-hour time period. So here in panel A, you can see the profile of NPH. It's definitely not a peakless insulin. It's sort of an intermediate acting insulin. And in comparison, glargine, which we used to call a 24-hour insulin and a peakless insulin, but in fact, you can see that it is not. And on panel B is Dedimer, which is similar to glargine, but perhaps a little bit shorter acting. And then panel C and D are the newer ultra-long basal insulins. So you can see that these basal insulins are true 24-hour, if not 48 or 72-hour insulins, and they are peakless compared to glargine. And so what does this mean? This means that the flatter profile, they have longer duration of effect, and so you rarely need to use these insulins twice daily like we sometimes do with glargine or detamir. They also tend to cause less hypoglycemia because they're more predictable, and in particular that's true in the overnight period. And you can also get some flexibility in the timing of dosing. So if you don't give it exactly at 8 o'clock every morning or 8 o'clock every night, you won't see that in the glucose control. So what if a patient is failing basal insulin? First of all, how do you know if they're failing? So if they're not at their at goal in terms of A1C or overall glucose control, once their fasting glucose target is reached, or if they're needing 0.5 units per kilo of basal insulin, you should strongly consider a basal plus strategy. So that could mean a GLP-1 if they're not already on it, or it could mean prandial insulin with the largest meal of the day. The largest meal of the day is a good option because the other alternative would be the meal that has the largest glucose excursion following it, and many of our patients don't monitor post-meal. So the general recommendation is to start 4 units at the largest meal, or you can do a weight-based strategy, and you can also do 10% of the basal dose, so just sort of rearranging the basal to the bolus. And don't forget, if someone is on a really high basal dose, that you consider reducing that and redistributing it. Another option is to use pre-mix insulin. I find this works the best in patients who have a regular schedule and who aren't skipping meals, maybe are able to achieve some kind of regularity with their dietary patterns. And then if they're not at goal, again, you can consider self-titration or assisted titration. If you're just starting off at the largest meal, it reduces that complexity in terms of titration, just titrating it to the 2-hour post-meal glucose value. And if they're still not at goal, then you can consider adding insulin at additional meals, consider pre-mixed insulin, and I have this little warning sign here, just some additional considerations is take a look at, are they taking it? Are there ways that you can simplify the regimen? Definitely refer them to diabetes self-management education. Are there other insulin-sparing therapies that might be useful here? Go back to, is there an indication or a possibility that you might be able to add metformin if they're not on it, a GLP-1, possibly SGLT2 inhibitor. Take a look at their carbohydrates, make sure that they understand the effect of adjusting their intake. And then think about more advanced options, which we won't really cover here, but those could be considered usually with specialty expertise. And so our third objective today is to look at the new technologies that are used increasingly for type 2 diabetes. Now these were introduced, CGM was introduced in the 2000s. So I believe even in 2006, we had the first CGM. So they are not, definitely not new, but they've gotten much more useful, more accurate, and more widely available. In general, they're recommended for all patients with type 1 diabetes, and they're at least paid for patients who have type 2 diabetes who are needing multiple injections of insulin per day. You might also consider them in patients who have issues with hypoglycemia, but I would not use them for patients whom do not have diabetes. There are 2 basic strategies. There's real-time CGM, where the data is immediately pushed out from the device to the receiver, which is either the phone or a handheld receiver, versus what we consider flash glucose monitoring or more intermittent, where you only get the data, as example with the Freestyle Libre, if you scan the sensor with your phone or the reader. And so these do have some slight differences. Both of them, depending on the model, can provide alerts for hyperglycemia or hypoglycemia to the patient. Some devices require calibration and finger sticks where others do not. So the Dexcom and the Freestyle Libre, for example, do not require fingerstick calibration. And you only need to do a fingerstick if you suspect that the data is not consistent with your symptoms, or if there are other things going on, like there's rapid glucose changes, if there's a low glucose and you need to confirm it. And also keep in mind that the first day of sensor wear for all of these sensors is the least accurate. As the sensor gets wet, it will be more accurate. And what do we do with this data? There are some accepted now targets for CGM because we're recognizing more and more that those patients with more advanced diabetes who have more variability, A1C doesn't always reflect those hyperglycemic and hypoglycemic excursions. So this is the standard targets for CGM in patients with type 1 and type 2 diabetes on the left. And then you'll see other populations like older and higher risk populations, patients who are pregnant. And so we'll focus on the left here, the 70% time in target of 70 to 180 milligram per deciliter is the general accepted metric. And then hyperglycemia defined as the percent of time above that, and hypoglycemia, the percent of time below that. And this is a standard means of reporting the data. So because there are so many time points, you can't possibly look at them all. So what this is an ambulatory glucose profile. You can see here the gray is the target zone. And this is presented typically 14 days, and they're all superimposed in this graph. The dotted lines represent the 10th to 90th percentile. The blue, dark blue lines represent the 25th, 75th percentile, and then the median is the orange. So you can see in this case, this might be a person who is over-basalized, because you can see that they are dipping a bit below 70 in those early morning hours, and then tending to rise later in the day, particularly post-supper. So this might be a person who would benefit from more supper insulin and less basal insulin. And so as we're moving towards technology, first of all, I just want to call out that there are some limitations, obviously, in our Medicaid population in terms of internet access, in terms of technological readiness in many other ways. And that's become increasingly clear with the COVID crisis. But in an ideal world, you would be able to do all of this remotely. The patient could be connected to their glucose meter, to their smart insulin pen, and they could be connected to our electronic medical record, and we could do this all seamlessly. So this is what the future of interventions are going to look like. At least one of the largest electronic medical records, Epic, is working on this kind of device integration. We're still a far ways off from optimal use. And the last technological advance that I just want to point out there is the smart insulin pens, especially for our patients who are not doing well on complex insulin therapies. These pens and their accompanying apps can help them dose their insulin. You can, in this particular example, it's called the InPen. The patient has an app on their phone, and you can do any of several different types of dosing strategies with just a set meal dose, or you can have them do carb counting, or you can give them a meal size, a big meal or small meal. You can change the dose by time of day. You can give them an exercise dose. If they're going to exercise, they hit that button, and then the calculator just spits out a dose for them. They then dial the dose up on their pen and go ahead and give the injection. Once they give that injection, it gets recorded by the app on the phone. So this does not link to a meter. That would be the optimal strategy, but these are things that are ongoing that are going to make it easier, I think, for our patients. And with that, I will stop. Oh, so yeah, so there was just a question about the GLP-1s. Yeah, I had the 10 units for basal insulin in there. I just forgot to take that one out. Yeah, the GLP-1s are dosed in, depending on the GLP-1, milligrams, for example.
Thank you, Kathleen. I'm just wondering, there's a word about the oral GLP-1 agonist, semaglutide. Have you heard any more news about it? I mean, I heard about it early this year that it was coming out, but I haven't seen anything else.
Mm-hmm. Yeah, the oral GLP-1 is semaglutide. It's called, the trade name is Rybelsus, and it comes in 3 dose increments: 3 milligrams, 7 milligrams, and 14 milligrams. You want to give it generally first thing in the morning. It absolutely has to be given on an empty stomach with exactly 2 to 4 ounces of water. You can't take it with any other pills, no other food or otherwise, because it is very finicky in being absorbed. So if a patient is open to an injectable, you can have that conversation. Is it easier for you to just do a shot once a week, or to do the oral Rybelsus? And for many people, I've actually been surprised. And there are many people who really still, that whole fear and that barrier of getting over the injection threshold is too much for them, and they would still prefer that oral. There's another question here. Is there an advantage to GLP-1s daily versus weekly? No, there's absolutely no advantage unless you're thinking about just sort of trying to mix a GLP-1 with a basal insulin. There are premixed formulations, but unfortunately they don't have great coverage across health plans. And Medicaid, you're better off going with separate injections. And really the efficacy of the GLP-1s, we used to say that the longer acting GLP-1s are more efficacious in terms of A1C reduction, but there's even small differences between individual GLP-1s. So the injectable once weekly semaglutide probably has the best glucose lowering efficacy of all of the GLP-1s. The shorter acting GLP-1s do tend to have better postprandial coverage. So if you're just looking for only postprandial glucose lowering, then you could consider that. In terms of tolerability, the short-acting GLP-1s tend to cause a little bit more nausea than the longer-acting, but there are also some differences between the longer-actings. The once-weekly exenatide, at least if you try to compile together data from multiple head-to-head studies of all of the GLP-1s, probably once-weekly exenatide has the best tolerability, but we don't have a head-to-head study of all of the GLP-1s. There was another one about combination. Are there benefits and/or risks of combination therapy using a GLP-1 and SGLT2 inhibitor? I think that's the next kind of really important clinical question to ask is there cardiovascular benefit or mortality benefit or other kinds of benefits of using both of them together? There's really weak data on that. However, in terms of glucose lowering efficacy, you definitely see additive glucose lowering effects. The exception might be if you're using an SGLT2 inhibitor in a person who has chronic kidney disease, you lose glucose lowering efficacy below an eGFR of around 45 or so. So you still preserve some cardiac and renal benefits below eGFR 45, but not the glucose lowering. There is also additive weight loss benefit from using both together. And of course, there's no additive hypoglycemia unless you've got insulin or sulfonylurea in the background.
I had a question about getting CGMs covered for patients with Medicaid. I had a patient last week who did amazingly well with a Freestyle Libre. I think his A1C was like 11, and he just loved his Libre, and he actually got off of insulin with his Libre because he was able to just kind of see how his diet was affecting his sugars. So then when we went the next year to like reapprove his Libre, it was denied apparently because he was off of insulin. And I just didn't know if there was any way around that.
For the Medicaid managed care plans, many of them allow you to send a prescription directly to the pharmacy, but they need prior authorizations. You usually have to send paperwork, and they'll only cover people who are on insulin. And I believe it's multiple injections of insulin per day, and they're not reaching targets. In terms of Medicare, it's even more dicey because Medicare requires that patients are checking 4 times a day and that you demonstrate or document that. There have been some waivers with the COVID crisis, but it's not been uniform across all of the Medicare plans. And Medicare also has to go through a durable medical equipment company, which adds additional complexity. I think there might be there may be some Medicaid payers that you still have to go through a durable medical equipment company, but I'm not sure about that. And then the private plans are variable. Oh, go ahead.
Oh, I'm sorry. I don't know what you guys think about this, but talking to patients with that issue about the Libre, one of the things I've thought about is the out-of-pocket price for the reader, I think is about $100, but then you keep the reader, or you don't need the reader because you have the phone. Then you get two sensors. You can have two sensors a month because they each last 14 days. What if, I'll pose this to a patient, what if you can afford, you buy the sensors out, but you wear it 2 weeks out of the month. So, you know, if you're off insulin now and you're doing pretty well, maybe you just need to wear it for a couple of weeks a month just to see how things are going. And then you're stretching the cost of the sensors out for 2 months. You see what I mean? I mean, you know, if you have to go out of pocket, because yeah, it's a game stopper when you're off of insulin as far as getting insurance coverage. But what if you're able to afford it? I think the sensors are, it keeps changing a little bit, but I think they're like $40 each and you get a pack of 2. So if it's, you know, if you could make that last over a couple of months, you'd at least have half a month with a sensor on just to see how things are going. That's one of the things I've discussed with patients, just trying to do a workaround like that. Then you can always beg the reps and see what they'll do, but sometimes they'll send one. But you know, that takes a link with a rep and begging.
Yeah, and Mary Lee made a comment as well about coverage. You could check that out in the chat.
Kathleen, this is Five Rivers. Can you hear us?
Yeah, hi.
A question, are there any cost effectiveness estimates or trials if you have patients on the GLP-1 and an SGLT2 over the course of a year or two?
And you raise a really good question. Aside from the efficacy data, which, you know, looks great, fantastic, what does this actually look like in clinical practice? The big issue is it comes down to, is the patient actually taking it? And so in real world studies, you generally see you know, reduced effects, and there's still real world data that has demonstrated cardiovascular benefits. And I, off the top of my head, I can't remember any individual studies on cost effectiveness, but it's not cost. I think it's in terms of quality of quality of life years adjusted, that it's considered cost effective, but I'll have to get back to you on that one. I'm 99% sure that is the case. Mary Lee, I wonder if you happen to know anything about that?
I'm not sure if this answers Dr. Lamb's questions, but there are studies that look at like the quality for like number of times of having to inject, or not inject, but like check your blood sugar, and like comparing like what the patient's medication regimen is. I saw it recently. There's like a statement on the AAFP website that kind of talks about that. I can find that and send it out. I'm not sure if that'll answer the question, but I know it kind of leads down that road a little bit.
Yeah.
So Kathleen, there was a call through PCORI for comparative effectiveness studies of all newer diabetes agents, including SGLT2s and GLP-1s. We actually applied for it. The lead organization is St. Luke's in Kansas City. And so they're going to compare them in terms of key outcomes, cardiovascular outcomes primarily, including heart failure, hospitalization, in an observational format. So they haven't studied them head-to-head, but my understanding is from a cost-effective standpoint, just like you, I think, you know, because of their ability to prevent heart failure hospitalizations, which are very expensive, they actually wind up being cost-effective overall. Mm-hmm. So I just have one question to anybody with, especially if you have knowledge of Medicaid. What are the criteria for starting an SGLT2 or GLP-1? Because I keep getting, they have to have failed metformin or uncontrolled on metformin. Is that still the case?
Yes. Yes, it's step therapy. Well, I think we have to move to our case study here. I know there are a couple more questions. If we have time, we can address them at the end.
Valerie, does he smoke?
Yes, he does.
Whether there are diabetes specific, because it sounds like his A1C is okay. Was that from, is that pretty recent?
Yes, that was on his initial visit. That was a point of care A1C. And so we'll draw a serum on his next visit.
Is he cognitively impaired? What are his mental health issues?
We don't know the exact diagnosis, but right now he is very angry of his situation and why he has become homeless, and does not want to take his medication. And
So he wasn't always homeless then. This is a reason.
no, correct. Yes. And this is what we're seeing quite a bit right now. People who've never been homeless becoming homeless because of the COVID crisis.
I wonder if Sharon or Karen, if you have any thoughts in general on helping patients who are homeless manage diabetes.
So I do see in the chat, is he a veteran? We certainly will work to find homes for all veterans. And we have home care programs, a special primary care for those people who have mental illness and just can't attend regular primary care, don't do the follow-up that's needed. So we actually follow them up. We send people to their homes for primary care ongoing. But the other thing for checking blood sugars, ostensibly he's not taking any meds now, so his sugars could be high, and that A1C is old, and it would be a danger if he was on hypoglycemic agents. But we do, if he is a veteran, we would provide a continuous glucose monitor if he's not able to check his own blood sugars. And that would be ongoing if he can learn to use it. We also put a professional 2-week CGM on, to see if it's needed. But we would use a device if he could use his left hand, like, I can't think of the name of it. I was trying to think of it, that the nurses use inpatient, where they just, poke a finger to get, it's an individual device that you throw out each one. It's easier to hold instead of a lancing device from the meter companies. So we give those to patients who have dexterity issues to be able to check their blood sugars. And if he couldn't do that, he'd get a CGM.
And I do believe he did say he was a veteran, but a lot of the veterans don't like to go to the VA. So I will.
We sure are seeing a whole lot more come because of COVID and homelessness and, oh my goodness. Yeah.
Thank you. I appreciate that.
And this is Karen. The only thing I would, want to see is what kind of support services, he could get. So I don't know if anybody in your office could look into, is there diabetes navigators, community health workers, some kind of support services that could kind of help him navigate and get assistance. If he's older, I don't remember if you said how old he was, but if they're older, the Area Agency on Aging will connect them with services and food delivery and things like that. So I would just try to get his permission to share his information with support services.
Okay, thank you.
Dave, Aaron just, put in the comments also, thinking about this whole concept of A1C, just always thinking about, okay, how do you know if your A1C is accurate? And in particular, in some situations like anemia, there's some, potentially even some racial differences that the A1Cs and things like hemoglobin S or C that might affect A1C, and it's always good to try to have some glucose monitoring data if you can, but I think we also recognize that some of our patients who aren't on therapy or who are just on metformin probably don't need to do regularly. So there are maybe some strategies to think about there. Oh, Dr. Kendi White is on.
Did this patient have coronary disease? Do we know?
No diagnosis. He's got hypertension, and I don't have his back records yet from his primary care to know everything that's going on with him.
Let's say he does.
Yes.
But if he does, then definitely adding a GLP-1 agonist or SGLT2 inhibitor would be a great next step. You know, there's some considerations with each of the individual ones, so kind of depending on his case, but both of them have been shown to reduce risk of recurrent cardiovascular events. So, yeah.
Great, thank you.
Yeah, so basically if someone has one of those conditions where their A1C is not reflecting their average glucose, oftentimes you can see that pretty clearly with a professional continuous glucose monitor, or there are other alternative glucose markers like fructosamine or glycated albumin that could be used. But the A1C is not useful in some in some of these patients, and so you have to rely upon those alternative methods.
Yes. Well, especially with his BMI so high, I just was concerned. But, yeah.
So, so since the patient has cerebral palsy, I wonder if there would be any housing resources available since he has a disability.
Yes, and the case manager is working on that.
This is Mark from Metro Health. I was trying to find the resource, but I know at Metro Health we have a new Epic referral system that I believe links us with other social service agencies. Does anyone else know about that? I think it's Ohio-wide, and that could be useful for Valerie on one end or the other.
Okay.
Yeah, this is Jim Warner at KCUH, and I just thought I might comment a little bit about the behavioral aspects of this. It's very interesting. So the patient really, showing signs of hopelessness with a lack of interest in his care, and this is showing up in his physical care and his lack of hygiene, even let alone his interest in controlling his blood sugars and his long-term the impact on his long-term health. So I agree with the suggestion earlier about engaging a community health worker if that's possible, or someone from your agency, to establish a real relationship with the patient where they're at the shelter. And then at the same time, as was mentioned, work to get the patient some long-term housing, which may be a lot at the root of why he's feeling so much anger, but we don't really know a lot about that. You were saying depression is pretty apparent, and so possibly treating depression, because depression can be manifest as anger as well.
Right.
And it can really, greatly sap a person's ability to care for themselves in the first place. So if depression can be addressed, then you might be able to eventually kind of peel back the onion and ultimately try to get to what matters for this patient. And if there's nothing there because of the hopelessness, what are his core values? And then from there, build up some motivation to take care of himself. So using a motivational interviewing framework. So I would just offer that. I think, engaging a community health worker, the resources that were mentioned earlier, and getting him housing would be really key. And then addressing some of these behavioral and psychological issues as well.
I appreciate that. Thank you. Well, this was very helpful for me. I appreciate all the suggestions and comments as well.
Okay, thanks everyone. There was just one more resource in the chat, which I think I could use to send out the next time I send out a message to everyone. Just new this week, we have sent 2 surveys this morning from REDCap. So we have 1 week. If you will please update your contact information so that we can share it with the cardio leadership team as part of our internal program evaluation. And also we share a cohort contact list at the end of the series with everyone. It just includes your name, your email address, and your practice name and location. If you wish to opt out of sharing your contact information, please give me an email, shannon.switkowski or just shannon@case.edu by next week. Otherwise, we'll compile that information for you and send it out. As always, you can watch our previous recorded clinics on the website. You just have to register first. And lastly, we just ask if you complete your post-clinic survey by Friday at 5 p.m. and we'll send information to claim CME credits at the end of the series. So next week we have, if you recall, we swapped our presentations with for week 2. So we have now the impact of type 2 diabetes on minority populations with Dr. Adam Przinski for next week. So you have a couple of minutes early today. Thank you for joining us, and we'll see you next week.
Thanks, everyone.
Thank you. Bye.
Thanks, Valerie.